Today is the second session of the Heart Failure Foundation's webinar series. This entire series is dedicated and aimed at achieving excellence in the field of cardiology, and this entire section has been devoted to cardiomyopathies. Today, we open up the second in the series, that is learning from the masters. This session is focused on hypertrophic cardiomyopathy. To moderate today's session, we have the eminent Dr. Hisham Ahmad. He is the Associate Professor in the Department of Cardiology at Amrita Institute of Cardiac Sciences, Kochi. Academic excellence, DM from Amrita in 2002, followed by Fellowship in Interventional Cardiology in Amrita 2013. He's a gold medalist in MD as well as in DM cardiology, a very academic and accomplished cardiologist. He's the lead for the Amrita Hypertrophic Cardiomyopathy Clinic and Registry, which is the first and the largest dedicated center of excellence for hypertrophic cardiomyopathy. At present, this is the largest series as well as registry in the country with a focus entirely on hypertrophic cardiomyopathy. So I hand over the stage and the screen to Dr. Hisham to introduce today's speakers and chairpersons. Over to you, Dr. Hisham.
Thank you, Dr. Bakirith, for that generous introduction. So good evening, ladies and gentlemen. So today, on behalf of the Heart Failure Foundation, I would like to welcome you to the webinar series on cardiomyopathy. And as has been alluded by Dr. Bagirith, today we are focusing on hypertrophic cardiomyopathy. And within the spectrum of hypertrophic cardiomyopathy, we will be focusing on two very crucial aspects. And the first talk that we will be having is a talk on the heart failure management issues within hypertrophic cardiomyopathy spectrum. And the second talk, we will be covering multimodality imaging in hypertrophic cardiomyopathy. And to start off today's program, so I would have the pleasure of introducing the first speaker. The first speaker is Dr. Anantram Kalyan. He's the staff physician and the advanced heart failure in the advanced heart failure transplant program, as well as a cardio-oncology program at the Banner University Medical Center, Phoenix, Arizona. He is also the Director of Cardiac Rehabilitation at the Banner University Medical Center, and he has a current designation of the Associate Professor of Medicine at the University of Arizona. His clinical interests include heart failure, pulmonary hypertension, cardio-oncology, women's health, and echocardiography. So we also have an illustrious panel of chairpersons, and joining me today evening is Dr. S. Harikrishnan, from the Sri Chitra Institute, Trivandrum. Dr. Harikrishnan is no stranger to us. He has had an illustrious career over the last decade. He is currently professor in cardiology at Sri Chitra, Trivandrum. He has a marked interest, substantial interest in the heart failure syndrome, and he has been at the forefront of investigation of heart failure in terms of conducting various studies and registries concerning the field of heart failure. He's also the principal investigator for the National Heart Failure Registry funded by the ICMR, and he's also the principal investigator for the National Center of Advanced Research and Excellence in Heart Failure. And he has a whole range of more than 100 publications to his credit. Joining him is Dr. A.G. Gokhale. He's a cardiothoracic surgeon, transplant, and minimal access cardiac surgeon. He's joining us from Hyderabad. And he has the unique distinction of having performed India's first heart-kidney combined transplant. And he has numerous publications to his credit, and he has specialized areas of interest, which include the role of injecting stem cells into the myocardium, essentially looking at the stem cell model of heart failure management. His other areas of expertise include minimal invasive heart surgery, including beating heart surgery and minimal access mitral and aortic valve surgeries. And he has an extensive interest in the field of heart and lung transplantation and the implantation of LV assist devices. Joining us as the third chairperson is Dr. Deepali Saxena. She's the senior radiologist, consultant radiologist and lead cardiac imaging specialist at the Columbia Asia Hospital Radiology Group. She has a broad spectrum of interest in cardiac imaging. She is academically she has quite extensive academic achievements, and she has been a faculty on numerous radiology as well as cardiac imaging forums, and she'll be joining us to chair this session. So without further ado, I would like to hand over the proceedings to Dr. Ananthram Kalyan to take over and to proceed with the first talk of the evening. Over to you, Dr. Ananthram.
Good morning, everybody. Such a pleasure to be amongst the elite cardiologists and cardiothoracic surgeons. Thank you so much for giving me the opportunity to be here this morning and share some of the work that we have done. And also, actually, it's a mutual learning process. So it's never going to be, so there's a lot of things, the experience that you have, especially Dr. Ahmed, having the hypertrophic cardiomyopathy clinic in Kochi, such an honor to be here. So, and thanks for the opportunity. So without delay, I'm just going to move on, and please, if you have any questions, I guess we're going to hold the questions till the end, if I'm correct. Unless there's some burning questions, feel free to interrupt me if needed. So the topics we're going to cover is just, I guess, give an overview and what are some of the risk factors that we know that may cause progression to heart failure amongst the hypertrophic cardiomyopathy patients. Are there certain stress testing? And I'm not going to touch too much on imaging, as we're going to have a talk following my talk. And briefly touch on the LV outflow tract obstruction and what some of the treatment strategies that are out there and how beneficial they would be. And what comprises end-stage heart failure and hypertrophic cardiomyopathy and the treatment options for end-stage hypertrophic cardiomyopathy. So we'll start with a question. I think it'll be sort of nice to open up, and this is the same kind of clinical scenario you face on a daily basis, especially if you're seeing some of these heart failure patients. A 35-year-old male who's known to have hypertrophic cardiomyopathy for 7 years, comes with worsening symptoms and shortness of breath. He's already on a beta blocker. His blood pressure is below normal, about 100/60, heart rate about 86. Exam does not reveal any JVD. He doesn't have a lot of lower extremity edema. He has no PND or orthopnea. It's exertional shortness of breath only, and nothing clinically other than the murmur that you hear. And it's a very soft murmur that you hear. So echocardiogram reveals thickened interventricular septum about 2.1 centimeter. And the LV ejection fraction is estimated at 55%. There's really no significant LVOT obstruction. I'm just going to minimize so I can see the screen here. So the question is going to be, in hypertrophic cardiomyopathy, all of the following are true, except LV ejection fraction less than 50% may be a risk factor for atrial fibrillation. MRI can predict worsening myocardial scar burden and hence predict advanced disease. Progression to heart failure is more common in patients with non-obstructive hypertrophic cardiomyopathy than with LVOT obstruction. Left ventricular assist device improves outcomes in certain hypertrophic cardiomyopathy with heart failure. Heart transplantation in hypertrophic cardiomyopathy patients with advanced heart failure carries the same outcomes compared to other cardiomyopathies. So we'll keep this we don't have to answer right now. We'll come back to this after we are done with the talk. So we know that, I'm sure you guys all know the answers. So, but we'll just cover some of these topics and look at the literature that's out there to substantiate our answer. So the definition, as most of you know, it's the most common genetic disease of cardiomyocyte in cardiology. Hypertrophic cardiomyopathy is. And the definition is usually hypertrophy greater than 13 millimeters. It's often asymmetric and without loading conditions, which means you don't have hypertension or aortic valve stenosis. Generally, these ventricles are not dilated. They're really small, in fact, and they all have preserved ejection fraction. So we always think about, okay, EF is 60%, so everything is fine. But it's so important for us to really look back into the images to make sure that the measurements is done accurately so that we can accurately screen for these patients. And generally, you can have an LVOT gradient with the resting gradient sometimes going above 30 millimeters of mercury. It's a common disease, it's an estimation of 1 in 500, even though this data is fairly old, and the more recent literature indicates it could be closer to 1 in 200 with the, with the advent of echocardiogram and the availability of echocardiogram around the world. So the prevalence probably we are identifying is much more common than 1 in 500. And it's an autosomal dominant transmission, so it is very important for us to look at the family members of those patients. So Dr. Ahmed might be able to pitch in and say more about these things, but I'm just going to give you a small study that was done in 2015 as to say this was done in Delhi, AIMS and the University of Delhi, where they looked at about 60 patients. And usually what they found was the onset was around 30 years. It's not uncommon, age of 30. And majority of those patients are non-obstructive is what they found, although it is a very small study. Male predominance was a common factor. 18% was familial. And the number of mutations, the percentage of mutations they saw in these patients was very low at 6%. And some of the presenting symptoms, we'll talk a little more about it. It's not very unique, but important thing is, they come in with chest pain and shortness of breath, palpitations, and syncope. And the interesting thing is the presentation was almost 14 patients out of those had actually New York Functional Class 3 and 4. So this also speaks to the importance of how we are screening the patients early on to identify if these patients have HCM, as opposed to they presenting at a later part of the stage with New York Functional Class 3 and 4. You may have seen some of these slides. On the left side, you can see very thickened, as a postmortem, obviously, very thickened left ventricular cavity, intraventricular septum, and free wall. And you can see the mitral valve leaflets and chordae. And sometimes the hypertrophy just climbs all over the chordae and involves, and some of the mitral valve leaflets might be very elongated. And on the right side, you see a normal endomyocardial biopsy specimen where you can see very pink, parallel arrangement of the myocytes with normal looking nuclei. And when you come to the endomyocardial biopsy of hypertrophic cardiomyopathy, you can see this perpendicularly arranged myocardial masses. And you can see the contractility in a normal, which is sort of unidirectional. And you can see the contractility that may happen when you have such hypertrophied cells and obliquely, irregularly arranged myocardial cells. So obviously this takes up more energy, and the efficiency of contractility is also hampered. And with the hypertrophy, obviously the lumen size, the LV cavity size decreases. And the hypertrophic cardiomyopathy comes in different flavors. So we always think about, okay, either the septum or the LV is thick. There's several flavors. Obviously, some of the others may not be as common as you normally see involving just the LV cavity. And rarely you can have right ventricular free wall also be involved. And depending on what this, it could be a mid-segment involvement. It could be very subtle, uniform throughout the LV cavity. It could be just the basal part of the LV that may be more involved. So depending on those, the presentation may be different. And when you auscultate and evaluate the patient, the findings may be different. So there's no one particular finding that you would, at least on examination, that you may pick up, or even on the echocardiogram, as long as you have a good clinical suspicion that a patient may fall into the category of hypertrophic cardiomyopathy, you might be able to identify these different patterns. Just a brief, I'm not going to go into the details of this. The commonest, so it's a disease of the sarcomere, which is the contractile element of the myocyte. And the majority of these abnormalities seem to happen around the thick filament, right in the middle. And the two different sort of mutation that may occur is, one is the commonest one is the myosin heavy chain, which is about 20% or so, and a myosin bridging protein C3, which could the second. So it's almost comprises about half the percentage of mutations that can be seen in these individuals. And the remaining of them are smaller, and they happen to occur in the thin filament involving the actin and the troponin elements. And here's a list of genetic abnormalities that have been detected, and then the functional aspects of some of these that can happen. So majority are still, we're still banking on one particular, the mutation is actually one, it's called a missense mutation. It's just one base pair replacement seem to cause these issues. And here you can see this majority of the patients may not have a mutation that you can identify. And we saw these two, the binding protein and the myosin heavy chain protein, and the remaining are really small percentage. And so the underlying mechanism we still bank on is called the monogenetic approach, where you have one particular gene affected as a result in the sarcomeric protein. And this seemed to cause all these secondary issues, which would be hypertrophy, the sensitivity to calcium is affected, and thereby you increase the cost of energy for contractility, which eventually takes a burden on the myocytes, leading to its failure. So the question is going to come. So when you look at the various different pathological findings in these hypertrophic cardiomyopathy, the question is going to come, is sarcomeric mutation alone able to explain some of the things that we see? That includes, the regional hypertrophy, apical aneurysm in certain individuals where you have very thick middle septum, or you have elongated mitral valve apparatus that affects the LVOT. And you also have arteriopathy. So some of these patients coming with chest pain may end up having, it's almost like transplant vasculopathy, if you may, very thick tunica media and very small lumen size. And you have severe fibrosis that obviously can lead to heart failure. And you have other submitral apparatus abnormalities. So the question always came up with sarcomeric mutation alone was able to explain some of these things. So here's one thing. So obviously the sarcomere is not present in the vascular area. So the question is, why does vascular abnormalities or even fibrotic changes that happens in the myocardium explain the sarcomeric abnormality? So then the monogenetic approach was sort of put on the side, and they're entertaining other issues that may be important. And this is so-called the endophenotypic spectrum is what they call it, where they not only have a genetic abnormality to start with, but after the genetic abnormality, there may be other pathways that may be activated, as a result of which that you have several other proteins that may be abnormal, resulting in different various issues. So that's the reason why it's so hard to predict which patient develops what, because it's hard to identify which particular pathway is activated in those patients. And there's also extraneous factors that may be important, where you have toxins or chemical exposures or infection, which we are not sure exactly what those might be. And the combination of these two with what they call as a network medicine that might be eventually converging into the pathologic or phenotypic abnormality that you see in these patients. So the features that you normally, the clinical features are not any different other than obviously you get concerned when the patient actually presented with sudden death where they have to be resuscitated in the field and brought to your hospital. So it's so important for you to look for hypertrophic cardiomyopathy as one of the differential. So they may have subtle symptoms of pre-syncope or dizziness, and palpitation, chest pain, and dyspnea on exertion is very common. Fatigue is another common presentation in these patients. And there's various underlying pathological abnormality, which I'm not, because of time constraint, not going to go into the details of each one. So LVOT obstruction is definitely one of those. And mitral apparatus abnormality, if there's significant LVOT obstruction and causing damage to the mitral valve, leading to mitral regurgitation. And of course, the arrhythmia part. So the LV systolic dysfunction is something that we always look for. And so what is about the LVOT obstruction and non-obstructive cases? Is there any difference in how these patients eventually fare when you follow these patients either in the outpatient or inpatient arena? So if you look at non-obstructive provocable obstruction, wherein you put these patients on a stress test and then see if the LVOT gradient increases or if there's rest obstruction. So if you look at the progression from New York Functional 1 or 2, where there are few symptoms to start with, if they progress to New York Functional 3 or 4, where they have majority of the symptoms, how do these different categories fare? So if you look at non-obstructive, so generally about 10% of these patients may actually progress to 3 and 4, and the rate is about 1.6% per year. But if you go to provocable, where you elicit a LVOT obstruction with exercise, where you do an exercise echo for that matter, and those patients are also at a higher risk compared to non-obstructive patients to progress to a higher functional class where they're more symptomatic. And if you come to rest obstruction, about 38%, which is a progression of about 7.4% per year. So it's important for you to categorize these patients as to where they really stand. It also speaks to the importance of doing an exercise treadmill stress test on these patients, because if you probably don't want to be happy just knowing that they're non-obstructive unless you really make sure that they don't have any provocable obstruction, because those patients may have to be carefully followed in the clinic. And so the hallmark of this progression and leading to death is really replacement of your myocytes by fibrosis. So once you see this, it becomes an important issue for you to be cautious about these patients. And then, and obviously we're going to have some MRI expertise in the talk after mine. So late gadolinium enhancement of these fibrotic scar you could actually place a percentage of what percent of the LV is replaced by fibrosis by using an MRI. And actually there might be value in serial MRI and also potential biomarkers. It's not commonly used as such. The question is, can we use some of the metalloproteinases or other fibrotic changes, abnormalities, or apoptosis or cell death abnormalities that you could detect in laboratories. So this is something that's it's being researched, as to say, if we could follow these patients by laboratory testing to assess if there's progression of underlying myocardial fibrosis. So just a brief thing, so MRI, so on the top panel, you can see the white scar. I mean, it's obvious is replacement of the myocardium, which is more dark like this. So you have replacement of the myocardium with the scar tissue, and pretty much becomes very extensive when they start having significant symptoms and heart failure issues. And that becomes important because if you look at sudden death events and follow up in year, the worse the late gadolinium enhancement, which indicates higher level of scar, greater than 20%, the risk of sudden death is quite high. So this becomes important for us to know what the myocardial fibrotic change would be in the myocardium. So the end-stage cardiomyopathy is more like you don't have a reversal, because a lot of these patients, when they present with shortness of breath and they have LVOT obstruction, you put them on beta blockers or you put them on pacemaker, their symptoms actually might regress or go back towards New York Functional 1 and 2. So that could be reversible, but when it gets to the point that it's not reversible, that's when you pretty much use the term end-stage cardiomyopathy, where they have symptoms despite maximum medical therapy. So they generally have obstruction, extensive interstitial fibrosis. Interestingly, atrial fibrillation always comes up, even though it's something that we commonly see in cardiology, but even in just general heart failure or cardiomyopathy patients coming with atrial fibrillation always suggest there's high likelihood of progression of underlying heart failure. So always have to be cautious when patients come with atrial fibrillation. And it's all the more important hypertrophic cardiomyopathy because they're at risk of developing not only worsening heart failure, but also they're at risk of having stroke, even though their LV ejection fraction might be greater than 50%. So this is an important category in hypertrophic cardiomyopathy where the LV ejection fraction is 50 to 59%, because as you all know that these patients have hyperdynamic LV contractility, at least in the initial phases. So when they start dropping to 50 to 59, they've also seen that these patients might progress to worsening heart failure in the near future, something that you have to carefully evaluate in these patients. And if you have a strong family history of end-stage cardiomyopathy, so if the people are dying or having sudden cardiac death or had a heart failure with HCM, those are some of the patients who may also be at risk of progressing into heart failure. So what does LVOT obstruction really do? This is more of a naive way of explaining why these patients from asymptomatic can go into functional class 4, so where they have high systolic pressures. This in turn may cause microvascular ischemia, causing further damage to the myocytes. And with the impaired LV filling, your cardiac output is reduced. Mitral regurgitation and high left atrial pressures may further worsen the patient's symptoms, and mitral regurgitation in turn may lead to pulmonary hypertension, which may further worsen their. So this is more of a gross way of looking at why these patients have heart failure, but obviously there are more mechanistic, microvascular, and other molecular pathways that might be important in this progression too. So if you look at, I'm sorry, I don't have any motion pictures, but you all understand this. So this is the LV, RV cavity, and you have to take my word for it. So this is the obstruction with the mitral valve coming in the way, and you have high LVOT velocities. So this is just a representation of what percentage of these patients become non-obstructive rest versus provocable. And so if you look at non-obstructive provocable obstruction, which we talked about, which is putting patients on a treadmill to see if they have obstruction, and you have obstruction at rest. So if you look at freedom from progression to heart failure, so if you have obstruction at rest, they are the worst. They progress much faster at a higher percentage to heart failure compared to those of provocable, which also does worse than patients who are non-obstructive. So if you have provocable and rest obstructive patients, that's important for them to be followed carefully. So if you look at survival, and here's when patients, so you have obstructive features and you go in and operate with myectomy, and patients who underwent myectomy for obstructive actually did well and compared to the expected population in the US. So they were pretty much the same. In fact, they did fairly well as a normal person. And when you keep these patients who have obstructive and they're non-operated, the risk of death goes up quite high. So what about non-obstructive? Do they really get heart failure at all? Yes, they do, but the progression might be a little on the slower side, if you may. So here's a case in point here, 31-year-old. This is a group of patients where they followed with non-obstructive hypertrophic cardiomyopathy. And so their initial evaluation was, and they're around 40 years old. By the time where they're placed, it's almost about 15 years for them to progress to be listed for heart transplantation for worsening heart failure. So I think the progression might be, it's closer to 5 to 7 years, if you may. in the obstructive, depending on the severity of the obstruction. And this might be more than a decade when they start having truly LV systolic dysfunction, LV cavity dilatation, progressing on to needing more advanced therapies. So if you look at sudden death, just a brief, because it sort of goes together with heart failure. Sudden cardiac death patients, the two commonest one listed here is one is coronary anomalies, 17%, and hypertrophic cardiomyopathy is much higher. There's several variety of other diseases that may present as sudden cardiac death. And so potentially patients presenting with sudden cardiac death, it may be important for you to screen. One, obviously, to make sure that their ejection fraction is not less than 50%, because those patients may need additional therapy. And then also looking for LV apical aneurysm. So we'll look at a photo of that. But these two can also predispose the patients, and a variety of other things, which I'm not going to go into details because of the time constraints, that predisposes patients. But definitely look for LV ejection fraction less than 50% and apical aneurysm that may promote these patients going into sudden cardiac death. And the 7 big listed here, we already know this, which is sudden cardiac death in a first degree relative, puts the patient at risk for a sudden cardiac death. So LV thickening greater than 30 millimeters, this is something that you have to be very cautious about. These are the patients who may require, even if you don't notice that they have syncope yet, or if they don't have arrhythmias, these are the patients that may benefit from ICD preventing sudden cardiac death. If they have unexplained syncope, even if you notice 3 to 4 beats of ventricular tachycardia in a hypertrophic cardiomyopathy, especially with obstructive features or non-obstructive features, those are the patients at risk of sudden cardiac death. Late gadolinium enhancement on MRI. If you see a scar burden greater than 15%, those are the patients that may be at risk. And LV dysfunction we talked about, and apical aneurysm. So the question that's going to come up has been looked at in several of the centers, and they're noticing that if your ejection fraction starts falling below 50%, those might be the patients who would benefit from an ICD preventing sudden cardiac death. This is what it's not a moving picture. So this is what a apical aneurysm looked like. On the left side here, you have a very small cavity. It's a contrast enhanced cavity. This is the chamber the wall thickness here. So in diastole, this is the space that you have. So you can assume how these patients can be symptomatic with such. This is almost like having an LVEF of 10%. As the cardiac output is so limited in these patients. So when you contract in the middle, so this particular patient has a mid-cavity thickening. So when you contract, it almost siphons the blood into the apex. So it almost sucks it in. So this is actually in systole. This is the amount of blood that's going to leave the chamber. And so when diastole, this actually comes out. So you can see this in this velocity probe here at the bottom. So in diastole, you can actually see one particular velocity here. And there's a halo here, not a halo, but a gap where there's no flow at all. And this apical amount of blood that's captured in the apex comes out in the second waveform. So this becomes important because sudden cardiac death and progression to heart failure is fairly common in these patients. And the 2 modes of testing, I hope I'm okay with the time. One is the exercise stress echo, which I think is an important thing to do when you see these patients in the initial phase, as we talked about provocable obstructive features, and cardiopulmonary stress test, which we commonly use in general cardiomyopathy patients who we are evaluating for heart transplant or durable LVAD or left ventricular assist device. That's a common test that's done. I think these 2 tests stand very important process in evaluating a hypertrophic cardiomyopathy. For people who don't normally do this, this is just, you could use it as a bike, you could use it as a treadmill. They're continuously monitored with the ECG and blood pressure. They have this face mask that analyzes breath by breath, oxygen intake and CO2 production. You can even have a arterial line, especially if you're concerned about pulmonary issues, to assess their ABG periodically. So this will tell you at what level that the patient, at what level of exercise the patient starts building up acid, where you start seeing the level of CO2 production increasing more than the O2 uptake. And that's basically what we assess as O2 uptake. And there's a cutoff that we normally use for heart transplant in general cardiomyopathy patients is about 14 mLs per kilogram per minute. So that's normally what we do for CPX. So, and then, and there's a study that they looked at about 1,000 patients undergoing CPT, and they followed up for about 5 years plus or minus 4 years. And their endpoint was death, ICD shock, sudden cardiac death, stroke, heart failure, admission. So they looked at if you were, let's say, less than 50%, they categorize this as 3 categories. One is greater than 100% predicted for age and gender. So you have algorithms for age and gender matched as to what they normally should achieve on a cardiopulmonary stress test. If you go greater than 100%, 50 to 100, less than 50. So less than 50, their freedom from composite events, which is the primary endpoint, was much less compared to patients who did better. And then also freedom from composite event, if you look at median, so the median here was 21 mLs per kilogram per minute. So if you were less than this, their event risk was much higher compared to patients who went. So in other words, it gives you prognostic information. And if the patient really is able to exercise well, his risk of either of these primary endpoints much lower. And briefly touching, without taking too much time, would be surgical myectomy, which is a preferred procedure for LVOT obstruction. And alcohol ablation is the other one. So this has always been, it's an age-old practice, and this is about maybe 2.5 decades old. And it's well performed in several of the centers. So what we look for when you actually ask these patients to be evaluated for ablation or myectomy procedure would be the clinical dyspnea, right? So they all have to be symptomatic, usually class 3 or class 4, where they have symptoms with minimal exertion, or they have near syncope that interferes with everyday activities. So this is a clinical evaluation. And if you look at the hemodynamic abnormality, usually it's a dynamic LVOT obstruction, which is greater than 50 millimeters of mercury. This could be at rest, or even if you provoke a high LVOT of greater than 50, and usually associated with septal hypertrophy and abnormality in the mitral valve. And the anatomic abnormality, obviously you have to have a good target, so you should be sufficiently thick septal for you to go in and safely and effectively either do the myectomy, or you have to have the appropriate septal vessels for you to ablate using alcohol. So, I mean, is it really that bad that you only have to do septal ablation with alcohol and consider everybody for myectomy? So here's a meta-analysis of 2,700 patients followed for about 7 years. They had both myectomy and alcohol ablation performed. So the conclusion in this was the long-term mortality was definitely aborted with alcohol septal ablation and myectomy, and they were fairly low. So nowadays in good centers where they do these cases, including myectomy, right? This is not an easy surgery. I'm sure the surgeon, I'm not a surgeon, but the surgeons here probably can vouch for it. I think it's important for you to have experience. It's important for you to have done several of these patients because it's considered a high risk in centers who don't have experience or haven't done much of these procedures. So, so the patients who underwent, the only caveat for doing alcohol septal ablation is that those patients are at risk of permanent pacemaker implantation, and they're at higher risk of needing additional septal reduction therapy. This is the only caveat that they found in this particular study. So the pros and cons is listed on this side. I'm not going to go into it in detail, but I think it's comparable is basically what they are coming up with. Success rate is about 80% in alcohol compared to the myectomy. So I think it's a very doable procedure. And here's another one, the class 1 indication here from the American Cardiology and Heart Association is experienced operators, comprehensive clinical program. In other words, you just don't want to do the procedure. You want to follow these patients tangentially over time. And then, and this is a procedure reserved for severe drug refractory symptoms. And it becomes the pros and cons for doing either myectomy versus alcohol. You know, if myectomy is the procedure, then if they are having other surgical procedures like bypass, definitely go for myectomy. And if they have AV blocks, right bundle branch block, complete heart block, then, you know, these patients, as I said, may require pacemaker anyway. So then alcohol ablation might be preferable. So this just came out recently, so I just want to touch base with this. So mavacamten is a myosin ATP inhibitor, which prevents the cross bridging of the myosin and thereby reduces the excessive cross bridging and decreases the hypercontractility. So this was published in 2018, where they found there was a reduction in the LVOT gradient with mavacamten in symptomatic obstructive hypertrophic cardiomyopathy patients. So they found several of these things to be beneficial. And, you know, this was a small study, as you can see the numbers here. So the LVOT gradient was better. Ejection fraction actually dropped, as you can imagine, that prevents the actual contractility of the myocyte. So we don't know what the long-term effect of dropping the LV ejection fraction from 70 to 50. Peak VO2, which is a cardiopulmonary stress test I was telling you, that actually improved in these patients, and dyspnea was also improved in these patients. So I think it's something that we have to look at the horizon, that mavacamten might be the important drug that hopefully once we get long-term studies as to how these patients do, especially sudden cardiac death, et cetera, if this would be beneficial in these patients. And this just was published recently in Journal of American College of Cardiology, where they looked at, it's more of a safety and dosing trial, where they looked at hypertrophic cardiomyopathy patients, and they followed NT-proBNP. As you know, this is a hormone that's released when there's significant myocardial strain, and troponin may also be elevated in these patients. They found a reduction in NT-proBNP and troponin in these patients treated with mavacamten. And this interesting thing was, this is non-obstructive hypertrophic cardiomyopathy patients. So this is something that we have to see down the road if this would be beneficial in a larger patient population and more follow-up. So coming to the how do we sort of evaluate when you see a hypertrophic cardiomyopathy? You know, you do an echocardiogram, you know what their LV looks like. Then you do perform an exercise echocardiography and categorize them as non-obstructive or provocable obstruction. And then you come down. So if they're asymptomatic, you continue to follow them. Mildly symptomatic, which I haven't gone into details, is medical therapy, includes beta blocker, disopyramide, and pacemaker. And drug refractory is where you can actually look at VO2 max and then consideration for transplantation. So if they have obstruction, either arrest with or provocation, and they have symptoms, definitely look for surgical myectomy. And mildly symptomatic, asymptomatic, usually medical therapy and surveillance alone should suffice. So always watch out when these patients come to you, long-standing hypertrophic cardiomyopathy, worsening symptoms. LV dysfunction is an important thing. So it's important for you to compare your echocardiograms to the prior ones. And when the cavity starts dilating is another indication that there might be significant myocardial scar. And if you're doing a CMR, if there's increasing scar burden. So you can see the variety of these patients. So here's a father and a daughter from the same family, obviously. One with hypertrophic cardiomyopathy, very small cavity, and they can progress to, and the father now showing signs of myocardial scar and large cavity size, and you have to take my word, LV dysfunction. So it can happen in the same family and with the same genetic abnormality. So going into the end-stage hypertrophic cardiomyopathy, here's about 118 patients that they followed with significant scar burden. So they looked at refractory hypertrophic cardiomyopathy, and this is the percentage of these patients that about 67% of those patients survived with transplant and ICD implantation, but 33% died. So there's a very high risk of refractory New York functional class 3 and 4 patients dying from heart failure. So this is an important group for us to monitor closely. And some of the patients who are stable with less symptoms, they fared fairly well with medical therapy and ICD implantation. And so if you look at end-stage cardiomyopathy, when the ejection fraction starts dropping, which is in blue, and non-end stage with preserved ejection fraction, there's sudden cardiac death, transplant listing, death from hypertrophic cardiomyopathy, and all-cause mortality is much higher when you see an EF drop in less than 50%. So it's important for you to remember that. And then, and the era effect, you can see that with the advent of the ICD, now you're comparing 2006 versus 2020, the sudden cardiac death is much lower in 2020 with the ICDs being more rampant. There are more patients being listed for transplantation, and there are fewer deaths compared to 2006. So can you really transplant because of the time, I'm just gonna move on to this, to the next slide. So functional class 3 to 4, as you know, listing for transplantation, you don't necessarily have to wait for ejection fraction to be 10 or 20%. They could be 40% if they're symptomatic. And the cardiopulmonary stress test I was telling you, 14 ml may not be required for hypertrophic cardiomyopathy because they could do even 20, but still be very symptomatic. And mortality among hypertrophic cardiomyopathy with severe symptoms is about 20%. So you have to be cautious about these patients. As you can see on the right side, hypertrophic cardiomyopathy, non-hypertrophic cardiomyopathy after transplantation, they do fairly well. I'm so very little p-value here, 0.04, but overall, comparatively, they do fairly well compared to any other cardiomyopathy that you would transplant. And what about LVAD? So the most important thing which are going, this is the Intermax, which is the database that they use where they have a list of durable mechanical circulatory support, looking at about 10,000 patients. The most important thing that they said, the hypertrophic cardiomyopathy with dilated, they're the ones that actually do better with LVAD. So the LVAD on general was greater, the LV end diastolic dimension was greater than 6 centimeters. So if you have LV cavity size, that's great. They do better. AF is fairly common. LV ejection fraction might be higher in these patients listed for LVAD. And actually, if you
Dr. Anantharaman, if I may interrupt for a moment, could we conclude the talk?
Yes.
Because we have another session. We have another speaker.
So the outcome with LV end diastolic pressure, if you have a LV end diastolic dimension of less than 5 centimeters, those patients don't do well with LVAD. So if it's greater than 5, those patients do fairly well. So those are the patients you should think about LVAD potentially. So look for these high features, worsening functional status, hypertrophic cardiomyopathy 5 to 7 years, especially if they're obstructed, onset of atrial fibrillation, dilated ventricles, EF less than 50%, high scar burden. Who would really benefit? You really have to have a center like in Kochi. I think that's a very good success story. Formalize multidisciplinary, access all appropriate treatment, early consideration for transplant. So the answer for this would be progression to heart failure is more common in patients with non-obstructive is false. Everything else is true because as you know, hopefully from my study, that heart failure is common with LVOT obstruction. And thank you very much.
Hisham, you are muted. Hisham, you are muted.
I'm sorry about that. Yeah. Thank you, Dr. Anantharaman, for that extensive overview of the phenotypic basis for the multiple mechanisms of heart failure. And I think since we're running short of time, I think we'll dive right into the next talk and probably we can field some questions in the Q&A after that. So I'm happy to introduce the second speaker for today, Dr. Ashita Bartosh. So she's has an extensive interest in cardiothoracic imaging. She's underwent a cardiothoracic imaging fellowship at St. Michael's, which is known for its heart, vascular, and structural heart disease program. She's been trained in congenital cardiac imaging at Boston's Children's Hospital, and we know that it's one of the leading congenital cardiac program centers in the world. I think she'll be talking on multimodality imaging in heart failure, in hypertrophic cardiomyopathy, and probably, I presume, with a specific tangent on CMR, evolving CMR data in HCM imaging. Over to you, Dr. Ashita.
Thank you so much for the introduction. I'll just share my screen. Okay. All right, so yeah, so I'm going to be focusing on cardiac MRI in hypertrophic cardiomyopathy, as that's my area of expertise. So the objectives of my talk today, what I'll be covering is why are we going to, why do we want to do cardiac MRI in hypertrophic cardiomyopathy, and what's the importance and utility of cardiac MRI in hypertrophic cardiomyopathy. The various phenotypes of HCM, we'll see a few of those cases. And I would be touching upon the risk stratification by imaging, and a little bit about mapping in hypertrophic cardiomyopathy, and a bit about the HCM phenocopies. So why at all image hypertrophic cardiomyopathy? Because first of all, to establish diagnosis, because without imaging, you wouldn't be able to establish a diagnosis of hypertrophic cardiomyopathy. And then once you've established a diagnosis, you would want to know what are the complications or what are the consequences related to hypertrophic cardiomyopathy that's there, like LVOT obstruction, mitral regurgitation, any risk of arrhythmia in these patients, and as important, importantly, any systolic dysfunction, and also to screen family members at risk. So why cardiac MRI? Because cardiac MRI is superior for segment visualization and tissue characterization, and it gives accurate measurements and observations, which would help in right diagnosis, prognosis, and treatment. So going into a small slide on echo versus cardiac MRI. This is my only slide with echocardiography, in fact. And this is just to show you the difference between echocardiography and CMR. And you can see that the spatial resolution of CMR is much better than echocardiography. This is a paper from 2005, but it's 15 years back, and the spatial resolution of CMR has increased much more than what this image shows. So, and you can also see that the wall thickness is quite underestimated on echocardiography compared to cardiac MRI. So with this in mind, what are the uses of cardiac MRI in hypertrophic cardiomyopathy? First of all, to assess the LV morphology, so the phenotypes of LV, the phenotypes of hypertrophic cardiomyopathy, and to calculate the LV mass to see even if it's hypertrophied or not, and for the assessment of maximal wall thickness, for risk stratification with the assessment of extent of late gadolinium enhancement, and in preoperative assessment by looking at mitral valve and papillary muscle anatomy for those, especially those patients who are being considered for invasive septal reduction therapy. So we'll look at all these things through cases. Let's first start with the phenotypic heterogeneity and HCM. And you can see the four most common varieties of HCM that you see is the asymmetrical septal hypertrophy, the concentric hypertrophy, and the mid-ventricular obstructive variant, and the pure apical form, or the apical HCM. The other phenotypes are isolated posterior wall hypertrophy, which has more refractive symptoms, isolated RV hypertrophy, which is very rare, and restrictive phenotype, which presents with much milder hypertrophy. So this is a slide to just show the different types of septal hypertrophy that we would encounter. This is a neutral septal morphology where it is quite straight towards the cavity. And in this case, it's involving the septum as well as the apex. And this is the most common variety of the sigmoid septal hypertrophy pattern, wherein the base is maximally hypertrophied. This is the reverse curvature morphology where it's convex into the cavity, and it's usually involving the entire septum and the apex. And depending upon where the maximal convexity is, it causes obstruction at different levels. And this is the apical hypertrophic cardiomyopathy, wherein the apex is thickened as compared to the rest of the ventricle. So let's dive into cases right away. And this is the first case is a case of a 26-year-old lady with recurrent syncopal attacks. This is a 3-chamber view. So you can see the LVOT here, the LA and the LV. And you can appreciate the asymmetrical septal hypertrophy really well. The hypertrophy appears to be maximum at the base. And you can appreciate the SAM really well here, which along with the hypertrophy is causing resting flow acceleration, LVOT flow acceleration. It's also associated with MR that you can appreciate. So what are the mechanisms of MR in or mitral regurgitation in hypertrophic cardiomyopathy? As we see in this case, ASH as well as SAM can cause MR. Intrinsic mitral valve abnormalities can cause MR, such as things that we would be seeing later in this presentation. Papillary muscle dysfunction too, we would be seeing. And there's a dilated phenotype of HCM where it can lead to mitral annular dilatation and cause MR. So for all this, a high resolution 3-chamber view would, or the LVOT view would be ideal. It would also show the site of LVOT obstruction really well. So let's look at the 2 and the 4-chamber views here in the same case. You can see the anterior wall is also hypertrophied. A bit of the mid-inferior wall also seems to be thickened. You can appreciate the MR here. This is the 4-chamber view. On the 4-chamber view, other than the things that we saw on the other views, you can also appreciate that the RV apex is also involved, or rather hypertrophied. This is the short axis stack, starting from the base at the bottom to the apex on top. And this is an important sequence because this is the sequence in which you would be measuring the wall thickness. A lot of times the obstruction or the jet due to resting flow obstruction can also be seen on this sequence. This sequence can also be utilized to look at papillary muscle abnormalities and RV involvement. This is a late gadolinium enhancement sequence, which is showing florid or significant scar, which is involving most of the apex, the mid LV, as well as the superior and inferior RV hinge points. If you look at the long axis views, the 3-chamber view is showing the significant scar burden in the mid to apical LV. So is the 2-chamber view here. And then the 4-chamber view is not showing it so significantly because it's mostly involving the anteroseptal segment, whereas what we're seeing here is the inferoseptal segment. So it's important that we see all sequences and all planes in order to diagnose the condition. So what is the definition of hypertrophic cardiomyopathy? I'm just gonna go through it really quick because it would be redundant after the previous talk. So LVH unexplained by any other loading conditions. It's usually seen in young individuals, and it's defined by a wall thickness of more than 15 millimeters, and a family history is present, and even 13 millimeters would suggest hypertrophic cardiomyopathy. What's asymmetrical septal hypertrophy? It's defined in normotensive individuals as 1.3 times the thickness of the opposite wall. And in hypertensive individuals, it's 1.5 times the thickness of the opposite wall. It's usually associated with SAM and basal hypertrophy put together would cause LVOT obstruction, and also is associated with mid to late systolic mitral regurgitation. So how do we measure the maximum LV wall thickness? It should be measured perpendicular to the wall. So it should be measured, initially we could probably measure it at multiple levels in order to get the accurate measurement of the wall thickness in short axis. So the consequence of HCM would be LVOT obstruction, mitral regurgitation, diastolic dysfunction, and myocardial ischemia, as explained very well on the previous talk. So let's dive into case 2. This is a case of a 40-year-old male with abnormal ECG. The echocardiography was normal. So what we see here on the 4-chamber and the 2-chamber views is apical hypertrophy. So the muscle at the apex is much thicker than the muscle in the base and the mid. And the myocardium is, you can also see that there is apical insertion of the papillary muscles. When you look at the 2-chamber view on the systolic face, you can see that it has an ace of spade shaped cavity. So this is a classical case of apical hypertrophic cardiomyopathy. The same case with the delayed enhancement on this case shows, on the long axis view, shows mild burden of non-ischemic scar. The same thing in short axis views also shows the same non-ischemic scar. So the diagnosis was apical hypertrophic cardiomyopathy with mild burden of non-ischemic scar. So apical hypertrophic cardiomyopathy, as I said, has an ace of spades appearance of the cavity, and it's seen better in end systole. In end diastole, the cavity opens up and it may lose that appearance. The wall thickness, in contrast to what I said previously, should be measured in long axis because the apex gets cut tangentially in short axis, and you would be erroneously giving either a smaller or higher measurement to the wall thickness. What's important is that it's not always very obvious, and it does not really hit the measurement of 15 millimeters on wall thickness for wall thickness. So therefore, you will have to look at the apical wall thickness, and if it's more than elsewhere, or if there's loss of apical tapering, then that would suggest hypertrophic cardiomyopathy. The other things that would obviously help diagnose apical hypertrophic cardiomyopathy or point towards it, other than imaging, is ECG abnormality, family history, and a small cavity LV with supranormal EF, which gives a clue to HCM itself. So let's look at the next case. It's a 25-year-old male with non-obstructive hypertrophic cardiomyopathy. The LVOT gradient was only 16. He complained of breathlessness and exertion. He had a family history of sudden cardiac death in 2 aunts. There was no history of palpitations or loss of consciousness. So this is the 3-chamber view, 2-chamber view, and the 4-chamber view. And you can see asymmetrical septal hypertrophy again. But what's different in this case is that the hypertrophy is maximum at the mid-ventricular level here. And SAM is not so obvious as in the previous case. You can see that there's systolic obliteration of the cavity on the 2-chamber view as well as on the 4-chamber view. So let's look at the level of flow obstruction here more clearly. This is a high resolution 3-chamber cine sequence, and you can see the resting flow acceleration here that's arising from the mid cavity when at the level of the papillary muscles when the walls oppose due to the significant mid cavitary wall thickening. This is the short axis stack again. This is the basal on the bottom, and this is the apex on the top. And what you can see is a typical spiral pattern of hypertrophy that you come across in HCM. So here you have the basal anterior segment involved, the anteroseptal, then going into the mid-infraseptal segment. Most of the mid-septal segment is involved, and also into the mid-inferior segment. And in this case, the apical segments are also involved. You should also look at the papillary muscle abnormalities in HCM cases. And in this case, you can see that this is the anterolateral papillary muscle here. It's a bit hypertrophied. And also you would want to ideally see the anterolateral papillary muscle in this area, which is the anterolateral aspect. But here it's also apically displaced as well as anteriorly displaced. So this is the delayed enhancement sequence, or the late gadolinium enhancement sequence, showing a lot of scar. This scar is obviously more than 15% of the myocardial volume. And on the long axis views, again, you can appreciate the significant amount of non-ischemic scar. So let's look at the importance of contrast-enhanced CMR in hypertrophic cardiomyopathy. It basically diagnoses myocardial fibrosis, and about 50% of HCM patients demonstrate LGE. The amount of LGE can be quantified as a percentage of the total mass, LV mass, and I will show you how to quantify that. The pattern of enhancement is diverse, but the most common kind of enhancement is seen in the hypertrophied segments and the RV hinge points. As Dr. Anantram said, more than 15% scar has been associated with twofold increase in sudden cardiac death events. And however, it is still debated. So it's the independent predictive value of LGE is still debated and therefore should not be used in isolation for ICD therapy decisions. So how do we use it then? If substantial LGE is seen, then it can help resolve complex ICD decisions in patients in whom the SCD risk is uncertain. So how do we quantify LGE? So this is an example of how I've quantified the LGE. You can use either of these two methods which correlate with histopathology, either 5 or 6 standard deviations. You basically mark an area of a nulled myocardium and then give 5 or 6 standard deviations, and then it would automatically detect the scar depending upon the signal intensity. And the other method is the full width at half maximum method. So case 4 is a 62-year-old male, hypertensive with ischemic heart disease, who presented with VT. The coronary angiogram was normal both in 2011 as well as 2019. Here is a case very classical of a mid-ventricular obstructive type of hypertrophic cardiomyopathy. You can see the thickening of the LV, which is restricted to the mid-ventricular level. This has led to the formation of an apical aneurysm, thinning and formation of an apical aneurysm. And in this case, you can also see a thrombus that's sitting within the apical aneurysm. This is a short axis stack, again, the base here, the apex here, and you can see that the thickening is maximum at the mid-ventricular level where there is complete systolic obliteration of the cavity. And as you go to the apex, there's wall motion abnormality with dyskinesis of the true apex. This is the late gadolinium enhancement images, the 2-chamber, 3-chamber, and the 4-chamber views. The long axis view showing the florid apical scarring extending to the mid-ventricular level. And as you look at the short axis views, again, this is the thrombus here, and you can see florid scarring in the apex extending to the mid-ventricular level. So apical aneurysms, the mechanism is basically the mid-cavitary obstruction leads to a high apical systolic pressure and adverse LV remodeling, leading to the formation of a thin wall scarred akinetic apex. The presentation is usually a dramatically abnormal ECG, and this form, you should note, is distinct from the apical HCM, which is confined to the apex. So LV apical aneurysm is almost always associated with transmural scar, like the case in which like the case I showed you. It forms a structural nidus for sustained monomorphic VT. And this is the only subgroup of HCM where radiofrequency ablation appears to be successful at treating life-threatening recurrent VT. So case 5 is a 56-year-old lady with syncopal attacks. She had a systolic murmur. It was diagnosed as HCM on echocardiography with a 16 mm basal septum and SAM, and had a high LVOT gradient of 87. Although the hypertrophy was less. So CMR was requested to assess the cause for LVOT obstruction. This case has been provided to me by Dr. Vishnu from Care Hospitals, Hyderabad. So this is a beautiful case example of an anomalous hypertrophied bundle that where CMR can actually help beyond just diagnosing the usual hypertrophy and the morphological subtypes. You can actually see this hypertrophied bundle, which is extending from the apex to the base where it attaches. This is the papillary muscle. You may think maybe this is papillary muscle, but if you come at the in the next slice, you can actually see the two papillary muscles separately and identify them very well. So this is the 4-chamber view, again, showing a bit of hypertrophy probably at the site where the bundle is attaching. And the short axis view, which is the most important here in order to follow the bundle. And you can see that this is the base, again, the apex. And from the apex, I'm going to follow the anomalous muscular bundle or the muscle, which is this. And this is the anterolateral papillary muscle here. You can see that the hypertrophied muscle bundle, which is again extending upwards towards the base and inserting here. If you concentrate on this image, this is the mitral valve here. And this is the bundle, the region where the muscle is attaching, the anomalous muscle. You can see that there is a flow acceleration of the defacing jet between the two muscle, between the muscle and the mitral valve, which is basically the region of obstruction. So here, the 3-chamber view very well shows the anomalous muscle bundle here, which is extending from the apex to the base. And you can see the mitral valve leaflet here, which is going and opposing to that area of where the hypertrophied bundle actually attaches. And you can see that in systole, and that's causing the defacing, jet, or it's the level of obstruction. You can also see in this case that the anterior mitral leaflet is elongated. This is a beautiful example of in-plane flow to show the flow obstruction caused by that at the site of the insertion of that anomalous muscle bundle. So the diagnosis was given as prominent apicobasal muscle bundle with a basal septal attachment causing LVOT obstruction, and the management was decided as surgical resection of that bundle. So let's look into what are the mitral valve and papillary muscle abnormalities that we could probably see in HCM. These are the mitral valve abnormalities and the papillary muscle abnormalities. You can have an elongated anterior mitral leaflet, posterior mitral leaflet, or both mitral leaflets can be elongated. You could have bifid papillary muscle inserting directly into the anterior mitral leaflet. Here, there's an anomalous anterolateral papillary muscle, which is inserting directly into the anterior mitral leaflet. And this has a caudate tendon attaching into the middle of the anterior mitral leaflet, which all would be leading to SAM. There are many more abnormalities that can occur, such as in terms of papillary muscle numbers, hypertrophy, and attachment. So how do we measure the mitral leaflet length? The best sequence would be an LVOT view like this in a high resolution sequence, where you can stop the sequence where it is where the mitral leaflet is pretty straight, and you can see the tip of the mitral leaflet, and measure from the aortomitral continuity till the tip of the aortomitral continuity till the tip of the anterior mitral leaflet. More than 24, you can refer to normal standard deviations, but more than 24 is usually considered as elongated. And the longer the mitral leaflet, the more the chance of obstruction. So what are the advantages of CMR in assessing these abnormalities? It can precisely identify the mechanisms responsible for LVOT obstruction, and it should be performed as a part of evaluation for invasive septal reduction therapy, so that before taking them up for septal reduction, they can decide whether papillary muscles or mitral valve needs any surgery. So what are the pre-phenotypic markers? As we saw, elongated mitral leaflet, papillary muscle abnormalities. And in this LVOT view, the cine sequence, you can see myocardial crypts here. So myocardial crypts are also considered as a pre-phenotypic marker. So multiple CRIPs with a family history in a first-degree relative would heighten the chance of sarcomeric gene mutation. But however, a single crypt is a normal variant. The other pre-phenotypic marker is septal convexity. So what's septal convexity? The group defined septal convexity as A minus B, that is the length of the septum minus the septal convexity. And they found that there was significant, the septal convexity was significantly higher in patients with HCM than without. So let's look into the next case, which is a 17-year-old female diagnosed as restrictive cardiomyopathy. Echocardiography showed biatrial enlargement with normal EF. You can see the hypertrophied LV. Looks more like a concentric hypertrophy. And you can also see that the atria are dilated. There's a bit of MR as well as TR. The same thing can be seen on the two-chamber view. The EF by MR was 41% LV and 43% RV. So there was biventricular systolic dysfunction. And we did, this is a TI scout image where you can appreciate that there is normal gadolinium kinetics. And this is the delayed enhancement view where you can see the scar, the non-ischemic scar in the mid LV. You can appreciate foci of non-ischemic scar here on the 4-chamber view and on the 3-chamber view and a bit on the 2-chamber view. The T1 mapping showed mildly increased T1 values and native T1 values, and did not did not point towards diagnoses such as amyloidosis, though it's not common in such an age group. And we diagnosed her as a restrictive phenotype of hypertrophic cardiomyopathy. So let's look at what's end stage or burned out HCM. It's seen in less than 5% patients. LVEF is defined by LVEF, which is less than 50%. The deterioration is progressive, but some patients may remain stable on early initiation of cardiovascular therapy. Let's look at the risk factors for sudden cardiac death in HCM. So we can divide them as risk factors, risk modifiers, and uncertain risk factors. And let's go into each one of them. So massive LVH is defined by LV wall thickness of more than 30 millimeters. It's a risk factor for sudden cardiac death, especially in patients who are less than 30 years. This measurement is actually based on echocardiographic studies, but even if CMR shows more than 30 mm, it should be considered for ICD for primary prevention. LV apical aneurysm, as I said before, the sudden cardiac death risk of those with LV apical aneurysm, unlike any other subtype of hypertrophic cardiomyopathy, extends into the 7th decade. But these are based on small observational studies. So therefore, decision regarding high-risk status based on just LV, the whole clinical profile of the patient should be taken along with LV apical aneurysm. As I said, the RF ablation is helpful only in this subtype of subtype of hypertrophic cardiomyopathy. And the pure apical hypertrophic cardiomyopathy without aneurysm, in contrast, has a low risk for sudden cardiac death. So in end stage of burned out HCM, the transition to LV systolic dysfunction, that's LVEF of less than 50%, represents a significant change because usually the EF in HCM is supranormal. And therefore, patients with LVEF of 50 to 60% have a risk of progression to HCM with LV systolic dysfunction, and therefore should be closely monitored. So the risk modifiers is LGE on CMR imaging, and LGE, as you can see on this late gadolinium enhancement view, is a nidus for ventricular arrhythmia. The presence and extent of LGE is associated with disease severity and arrhythmia. and considering LGE in totality would benefit ICD decision. So what's the potential role of LG in risk stratification? There are two scenarios here where there's no conventional risk factors, where it may prompt consideration for primary prevention ICD therapy. And the other group with uncertain risk, where if you actually find extensive LG, then it would go in for putting in an ICD. Whereas if there's minimal or no LGE, maybe you could consider against ICD. The pattern of late gadolinium enhancement is important because not everything is suggests sudden cardiac death, a risk for sudden cardiac death. So the most common pattern we see is the right ventricular insertion point enhancement, and that has been shown not to be associated with sudden risk for sudden cardiac death. So how would we use LGE? What's the prognosis of LGE? LGE on CMR imaging was associated with significantly greater risk for total mortality as well as cardiovascular mortality. And for every additional 10% of the myocardium being affected by LGE, there was an incremental increase in total mortality of approximately 30%, with an incremental increase of nearly 60% in cardiovascular mortality, sudden cardiac death, and heart failure death. So coming to the uncertain risk modifiers, the first one is myocardial ischemia. There's conflicting data on this. And this beautiful image of stress cardiac MRI has been provided by Dr. Vimal Raj from Narayana Health, Bangalore. And you can see the hypoperfusion here in the inferior wall. And basically, patients with HCM and coincident CAD have been shown to have mortality rates more than those with CAD only. So stress perfusion, yes, it has a potential role. You can have two types of perfusion defects. You can have a global diffuse subendocardial hypoperfusion, and you can have regional septal perfusion. So global perfusion may either indicate microvascular ischemia or it can indicate multivascular coronary disease causing myocardial ischemia. Therefore, when you see stress perfusion, definitely angiography should be considered. The other uncertain risk modifier is LVOT gradient. I would not go into details of this, but there are some practical limitations to use LVOT gradient because it's present in large number of patients, so it may lead to overtreatment with ICDs. And the gradients can change with drugs or invasive septal reduction therapy. So who are the low risk patients? Potentially those with an SCD risk of less than 0.5% per year, probably those with none of the 5 major risk factors, no or only mild symptoms of heart failure, left atrium of less than 45 millimeters, LV wall thickness of less than 20 mm, and LV outflow gradient of less than 50. So the next case is a 47-year-old asymptomatic male with hypertrophic obstructive cardiomyopathy. On routine follow-up, he was detected to have an elevation in LVOT gradient on resting echo. The patient was advised cardiac MRI for evaluation of myocardial thickness and scar assessment. So this is a 3-chamber view showing all typical features of hypertrophic cardiomyopathy with asymmetrical septal hypertrophy, SAM, as well as resting LVOT flow acceleration. But what do the LGE images show? It's very interesting because the long axis views are actually the scar. What you can notice here is subendocardial and not in the mid wall. So it's not a non-ischemic scar, but in fact an ischemic scar. So on the short axis views, you can make that out more obviously. It is subendocardial, it's abutting the cavity here, and it is not the typical scar of HCM that we've been seeing in this presentation. So you can see that the scar is involved in the inferior wall, the anterolateral segment, as well as the anteroseptal segment. And I'm just going to scroll through this image to show how it's extending into the apical anterior segment, apical septal segment in a typical LAD territory. Yes. So the diagnosis we gave was HCM with large LAD and limited RCA and a circumflex territory influx. they went ahead and did a coronary angiogram. He had a PTCA done in 2015 to the RCA. So this was the 2015 coronary angiogram where you see mild luminal irregularity in the proximal LAD. And this is the 2017 angiogram, which they did post our cardiac MRI report. And you can see that there is a tight stenosis in the LAD. So this is a still image of the same after progression of the stenosis. And the patient underwent CABG and with Lima and LAD graft and myectomy, and the patient's doing well on follow-up. So a bit about CAD and HCM. Coexistent atherosclerotic coronary artery disease can be seen in up to 25% of HCM patients above 45 years of age. The diagnosis is difficult to make on clinical grounds, secondary to the high frequency of angina in patients with HCM without coronary artery disease. And in those with coexistent coronary artery disease and resistant symptoms, CABG alone or in combination with left ventricular myectomy or mitral valve replacement has been recommended. So this brings us to the next topic about HCM mimics or phenocopies. This is not an exhaustive list, but these are the common ones that we would come across: hypertensive heart disease, athlete's heart, amyloid, Fabry, sarcoid, and myocarditis. In the interest of time, I'm not going to go into any one of them in detail. However, I'll just touch upon the role of T1 mapping in in HCM and HCM mimics. So you can see that T1 mapping is quite useful in differentiating amyloidosis. Amyloidosis has a very high T1, native T1 value as well as ECV value, whereas Fabry's disease, which is again a mimicker, has a low native T1 value. And these are in the guidelines. Native T1 is in the guidelines for the diagnosis of both these conditions. And other conditions such as sarcoid, acute myocarditis due to any cause will also have an increased native T1 value, more than that expected of HCM. So I'm just going to give you a few pointers on how to differentiate hypertension versus HCM, because it's one of our most common clinical scenario. And one of the important things is that when the LVH is by definition more than 15 mm, it would favor hypertrophic cardiomyopathy, but then it does not rule out that it's not because of hypertensive heart disease, because you can have an overlap of both hypertension as well as hypertrophic cardiomyopathy. So, but then if it is more than 20 mm, it's definitely hypertrophic cardiomyopathy. The other thing you can look at is the pattern of late gadolinium enhancement. If you have the non-ischemic pattern that we've been seeing, then it points towards hypertrophic cardiomyopathy. But if you have just the hinge point scarring, then that could also be seen in hypertension. The other things that can help is obviously age, ECG, and family history. So let's look at the role of T1 mapping in these. This group actually showed that the native T1 in hypertension was normal, and the native T1 in hypertrophic cardiomyopathy, even in gene positive and phenotype negative patients, was significantly elevated compared to patients with hypertensive heart disease. So how do we differentiate athlete's heart versus hypertensive cardiomyopathy, hypertrophic cardiomyopathy, sorry. So majority of athlete's heart, even though they are thick, are usually dilated. The key tip would be that in hypertrophic cardiomyopathy, the cavity size is usually small. And the wall thickness, as I said, for hypertensive heart disease, it's rare that athlete's heart goes to such a significant hypertrophy. And LGE, again, the presence of non-ischemic scar would point towards hypertrophic cardiomyopathy. And ECG abnormalities such as T-wave inversion beyond B4 would suggest cardiomyopathy. Other things are contractile reserve. One of the important things that we could do is probably follow up after detraining. And if it resolves, then you know that's athlete's heart and not hypertrophic cardiomyopathy. One thing we should remember that just like hypertensive heart disease and HCM, you can also have an overlap of athlete's heart and HCM. That is, athletes can have a hypertrophic cardiomyopathy. So let's go into the next case, which is a 29-year-old male with apical hypertrophy. I'm not going into obvious clinical details. So here you can see an LV 2-chamber view, 3-chamber view, and here you can see the 4-chamber view, and you can see that the apex is hypertrophied. Other than apical hypertrophy, what you should also notice here is that the RV apex is extending beyond the LV apex, and that means that the LV apex is probably slightly retracted. It's wrapping around the LV apex here, and the apical hypertrophy is actually obliterating the apex in both systole as well as diastole. In contrast to apical HCM, where you would see that the apical obliteration is more common in, is more obvious in systole rather than in diastole. Other features of restrictive cardiomyopathy, such as biatrial dilatation and some amount of regurgitation, valvular regurgitation is also seen. The 4-chamber LGE, or the late gadolinium enhancement, shows a typical subendocardial scarring with a V-shaped scarring with a sliver of thrombus, which is typical for the diagnosis of endomyocardial fibrosis. So the differential diagnosis in such a case would be probably apical hypertrophic cardiomyopathy, apical thrombus, and cardiac amyloidosis, which all could be differentiated by using cardiac MRI. So to conclude my talk, take-home messages, cardiac MRI in hypertrophic cardiomyopathy is useful in delineating and assessing the LV morphology, the LV mass, maximal LV wall thickness. We also saw how it helps in determining pre-phenotypic markers and suggesting possible hypertrophic cardiomyopathy. It helps in risk stratification with late gadolinium enhancement. It also helps us evaluate the left ventricular apex better than echocardiography, and therefore in the diagnosis of apical aneurysm and thrombus, if any. And it helps us determine mitral valve and papillary muscle anatomy better. And in cases where echocardiography is not able to determine the cause of obstruction, and therefore is helpful and should be done, CMR should be done as a preoperative assessment, especially in patients considered for invasive septal reduction therapy. A take-home point is not all thick hearts is HCM. So this is not an exhaustive list, but all. So we will have to consider other mimickers of HCM or phenocopies of HCM when we look at a thick heart on imaging. Thank you.
Thank you, Dr. Ashita, for that great overview on the application of CMR in the management of HCM. I think one cannot overemphasize the role of CMR in the management of these patients, right from the diagnosis, the prognostication, and this planning septal reduction therapy. So I think I'll dive right into some of the questions which have come up on the Q&A, and then I'll quickly open up the discussion to the panelists for their comments. The first question is from our panelist, Dr. Deepali Saxena. She's addressed this question to Dr. Anantram, and her question is, do you have a specific protocol for follow-up of HCM patients once their diagnosis is confirmed after a CMR? I presume the question is on a follow-up with CMR imaging.
That's correct.
Thank you for the question. So we don't have a specific as such to do an MRI on every patient, like every 6 months or a year, but if the functional status sort of jives with the presence of LGE scar in the past, we actually just proceed with advanced heart failure therapy listing at that point and closely follow those patients. But if somebody has, like as was said, maybe 10% of the total LV mass scar, maybe it's prudent. Maybe Dr. Barthura might be able to shed more light into it. We generally say maybe 6 months to a year. It may not be a bad idea if you're getting closer to class 2 or class 3 functional status. Sort of putting the entire picture together would what promote you to say that you need to do more additional testing.
Sure. And do you also screen the family members with what imaging modality do you prefer for that?
We start off with an echocardiogram. Obviously, genetic testing is definitely something that we would consider. as you saw, it's sort of waxes and wanes. Even if you have a presence of a genetic abnormality, the patient may not have have a phenotypic abnormality yet. But we definitely, in 3 to 5 years, we repeat an echocardiogram. And rarely we go directly with an MRI, but it's mostly echocardiogram and clinical follow-up.
Thanks.
The second question that we have is, I think, in the domain of heart failure, and I think this is addressed to the panel. And may I request Dr. Harikrishnan to take this question? I think the question concerns the use of SGLT2 inhibitors in the spectrum of heart failure in HCM patients. We have a lot of data, positive data on SGLT2 inhibitors over the last 4 or 5 years. And I think the question is to know your perspective on where do we place this particular drug class in the management of heart failure in these patients?
Yeah, SGLT2 inhibitors, I don't know whether it has been specifically tried in hypertrophic cardiomyopathy. It had been found to be useful in heart failure with reduced ejection fraction because of its different effects, including water diuresis, which reduces the congestion. Probably in patients who have a dilated form or end-stage HCM, probably this may have a role. In the true typical hypertrophic variety, I don't know whether there is any data to support the use of SGLT2 inhibitors in heart failure, in HCM.
Thank you. We have another question regarding LGE, and I think I would request Dr. Ashita to take this question. So the question is there a relation between LGE and the progression towards towards a reduction in LV systolic function? So is there some data, I think, is there some data with the degree of LGE in a patient, or let's say a cohort of patients, or cohort of HCM patients, and their subsequent evolution into end-stage heart failure?
Yeah, thanks for that question. So there's no association between the progression to systolic dysfunction and LGE, but LGE per se is, is known to be seen in the extent of LGE is more in patients who have quite a bit of already progressive HCM. So it's not that if you see LGE, this patient is going to progress into systolic dysfunction. You wouldn't be able to say that. If that answers your question.
Dr. Anandaram, would you like to comment on the same question?
Yeah, so no, I agree with Dr. Barthur. So you can't really say, okay, the LGE burden is about 20%. So invariably that patient is going to have LV dilatation and heart failure, but the risk definitely increases. And especially you have to add in if their functional class also declines on top of that. And it's so critical for us to really measure that LV ejection fraction so carefully. And on MR is obviously the best choice for you to go in for that. So that's where the issue comes in between 50% and 59% patients, right? So they have a 60%, so we may not necessarily pay close attention when the LV ejection fraction drops from 62% to 59%. So maybe it is getting to the fact that the patient might be slightly getting into LV dysfunction category and progression in the scar burden. And replacement of any myocyte with scar obviously causes LV dysfunction if you look at any general category as such. But the precision is so important here. The likelihood is high for progression, but not necessarily predict as such this particular patient will proceed to LV dysfunction.
Thank you. Just there's a follow-up question. In fact, it's a question of my own. So its question is Dr. Ashita. So you mentioned if you look at the LGE data, which is coming, which's been there in the field since the last 4 to 5 years. I think there's been this ever since the landmark paper from Raymond Chan, which said anything more than 15% is a high risk for adverse cardiovascular outcomes. So in your routine work, when you report LGE, do you actually quantify in terms of percentage of the LV mass? Or because this is a number which it's potentially acting like an arbitrator, right? Especially when the patient is in a gray zone, you're thinking of an ICD implant or not. So do you see any limitations in relying on just a number when you're reporting LGE for the clinician?
So to answer your question, we do quantify LGE, especially if we think that it is more than just mild. So if it's mild, that is just focal scarring here and there and RB hinge points, then we may not quantify it. But if by any chance we feel that qualitatively we would assess the case, and if we feel that there is, even a moderate burden, then we wouldn't want to take a qualitative decision on that, and we would use, like how I showed you the picture of how I quantify LGE. So I do that for almost all cases where I think that the scar burden is moderate, and I do give the number. I do give the number as a percentage of myocardial volume.
Yeah, thank you. Thank you. We have a question addressed to Dr. Ananthraman. So this question is regarding an ICD. So once you've decided to implant an ICD, the question is on myectomy and ICD. So once you've taken care of the obstruction, let's say a patient has severe LVOT obstruction, and once the patient has undergone, let's say, a septal myectomy for septal reduction therapy, how would you assess his SCD risk in the subsequent phase? If the patient had a baseline high risk of SCD, does the fact that the patient has undergone a septal myectomy change your clinical decision to implant an ICD later?
All right, great question. So I wish I had the right answer for that. But, I guess going into the ICD itself, you would obviously, look at the patient as a high risk for sudden cardiac death if you're implanting an ICD. So the myectomy per se may not necessarily change the fact that the patient is at risk for sudden cardiac death, especially if you've had pre-syncope or syncopal episodes. And of course, if you've done a cardiac MRI showing significant scar burden, those patients are at risk no matter how you look at it. Myectomy, obviously, you're improving the symptoms as such. So if they're coming in with class 3, class 4 heart failure, have significant gradient across the LVOT, and despite being on medical therapy, including beta blockers, et cetera, and you've done a myectomy, then obviously you already have an ICD, and that decision is not going to bear on a myectomy as such. But I guess the most important question here is, how will this patient progress down the road? Because you've already done a myectomy, they already are at high risk of sudden cardiac death. What is their burden of worsening heart failure down the road? So that's something, these are the patients we closely follow and make sure that their functional class actually improves. And with repeat echocardiogram and close follow-up, really help you identify, because these are patients, these may be early on you're seeing these patients, or it could be 6 years, 7 years after the initial diagnosis of hypertrophic cardiomyopathy. So those are the patients that you have to worry about heart failure progression down the road.
Thank you. So let's assume the patient has a baseline of, let's say, 20% LGE and has severe LVOTO. And so right now we know at baseline, this patient has a high burden of LGE, and this patient subsequently goes to get a myectomy done. So in that case, would you be more towards lowering your thresholds for an ICD for a patient with a high burden of LGE?
Actually would lower the threshold, absolutely. Because this is another study that they looked at in Europe, where in 2010 it was published, where they actually came up and said patients who are undergoing myectomy had a higher risk of progression to heart failure, even though the subsequent sort of evaluations led to the fact that there was no higher risk for myectomy causing heart failure as such. It just tells you the underlying milieu of what the myocardium truly is. So if these are the patients who are already at high risk for heart failure and you do a myectomy, those will continue to be at high risk for heart failure as such. But you may improve the symptoms, but hopefully a close follow-up.
Yeah, thank you. The next question is an imaging question. I'll ask Dr. Dipali to take it. So the question is, how do you differentiate on CMR, HCM of the sarcomeric type from cardiac amyloidosis? So could you share some imaging characteristics?
Yeah, so amyloidosis has a very, very characteristic pattern. Generally, it's a diffuse subendocardial enhancement that happens in a non-vascular territory and involves the entire ventricle. It can involve the valves also, they will enhance, and then the atrial wall will also enhance, and the septum will be a little thicker, interatrial septum, I mean. So that is a very characteristic picture. generally, and whereas HCM will have, as Dr. Ashita has pointed out, all the varieties that you have. So the pattern of enhancement is most important, and of course then the clinical picture of the patient.
Okay, thank you.
Maybe I could add another point there. So I'd shown in my presentation that parametric maps would help in this case because T1 mapping is in the guidelines of for the diagnosis of cardiac amyloidosis. So if you have access to parametric maps, if the place the patient is being scanned has an access to parametric maps, it's a clear advantage over places which do not, because parametric maps in cardiac amyloidosis with native T1 value and the ECB is much, much higher than what you would expect in hypertrophic cardiomyopathy. As Dr. Dipali pointed, it's quite characteristic most of the times, and it's very easy to differentiate the two on imaging most of the times. But in cases where you could have hypertrophy and SAM as well as LVOT obstruction, and it's an elderly patient with hypertension, and the LGE is very typical for cardiac amyloidosis, then you'd be stuck. And there probably you could use parametric maps, and that would help you probably help you not do a cardiac biopsy.
Yeah, and I agree, and that's a very important point. Also, at the time of acquisition of an MRI, in case of amyloidosis, the first and foremost pointer will be the tech will call us to tell that, doc, I'm having a problem. I can't get a proper nulling value for the myocardium. And that's a very important thing, because that's a straight away blood pool appears darker in amyloidosis at a time when it should have been bright. And this mismatch will happen. We will not be able to get a nulling point. That's a clue to amyloidosis.
No, I think I completely agree with both of you, and I think Dr. Ashita, I think mentioned it in passing, and I think for want of time, I think you didn't elaborate on HCM phenocopies. So at our institute, in our cohort, we've had the interesting experience of having reclassified some of our HCM patients which were diagnosed earlier into Fabry disease. And when we ran them through the CMR, we found that the T1 values were low. It probably represents glycosphingolipid deposition. Then we do the genetics, and we find that the phenotype of HCM is there, but actually the genotype is completely different. So the treatment is different, the prognosis is different, and I think that underlines the role of multiparametric imaging in HCM. Yeah.
Right.
I'd like to open for any further comments from the panelists. Harishan sir,
Yeah.
Dr. Gokhale sir, yeah.
I'd like to ask a couple of, go ahead, Professor, a question.
Yeah. No, one question to Dr. Anantharaman. You see this apical ballooning. So we know that patients are prone to thrombosis also. Do you routinely put them on oral anticoagulants?
Absolutely. So that's a great question. So we don't know if apical aneurysm per se increases the stroke, but obviously the cardiac MRI Dr. Barthur showed, had a presence of thrombus. The most important thing obviously is atrial fibrillation, even if the ejection fraction is 55%, and we can't go with the normal exclusion of who goes on anticoagulation or not. But if atrial fibrillation is present in hypertrophic cardiomyopathy, definitely we will put them on it. We have to weigh the benefits and the risk of just apical aneurysm per se, but I would tend going on anticoagulation for those patients, especially if the bleeding risk is very minimal.
Yeah, one more thing you mentioned about the risk of pacemaker implantation in patients who undergo alcohol septal ablation. So what we have been doing recently is that there is a cutoff of 1.5 ml of alcohol. Probably if you exceed that cutoff, the risk is going to be higher. So we always limit, even though the relief of obstruction is not that much. We stop at 1.5 ml and see whether the patient has a reasonable outcome rather than going for a pacemaker.
Great point.
I think They were great presentations. Actually, as a surgeon, I thoroughly enjoyed both presentations of beautiful MRI angiofilms. I got a few questions, Dr. Anantharaman. The first is, I have a patient who has got a significant obstructive cardiomyopathy. He is on beta blockers and he says he is asymptomatic. In fact, the gradient reported at Bangalore, the place is about 180 millimeters of mercury. Wow. And he says it's NYHA class 1. He is just going for follow-up. If a patient is asymptomatic and a beta blocker with such high gradient, do we go ahead and treat this patient with some form of myectomy?
Great question. So you know some of these patients, how hard it is to get if they're truly symptomatic or not. So you just have to take it with a grain of salt. That's number one, especially with the obstructive gradient of 180. That's beyond what I've seen personally. So, I mean, I would definitely put him on if he's that asymptomatic, cautiously, I would put him on a treadmill to really assess what his true functional capacity is. And I'm likely he's not going to pass the middle portion of your stress test. So very likely he's going to get symptomatic or hypotensive or have other issues. So there's something that I would do it cautiously, but definitely that high gradient is a risk factor for being symptomatic and progression to other complications. So I would truly consider myectomy at that point, but once again, carefully assess and document that his functional capacity is truly class 1.
Related to this, related to this, when you assess the patient with a stress test for a provocable gradient, do you in what parameter or what test will you do it in the cath lab? Do you do an ectopic NC or do you really exercise the patient? If you are taking,
I truly exercise the patient. So I mean, we do have a cath bicycle that we can utilize and reassess filling pressures and that sort of a thing. But we would just put him on a general treadmill or a bicycle and just exercise. We can do a stress echo. We just rotate the bike over and do a stress echo, which might be the best thing that we do, at least in our practice.
Some of the patients we get for surgery often have got significant mitral incompetence along with this. So we end up doing mitral valve replacement also for these people. Do you think in these patients, if I just do mitral valve replacement without resection of the muscle, would that give adequate relief? Because after all, it is a problem of the whole cardiac muscle. And once I do a mitral valve replacement, the outflow gradient is likely to drop in. What do you think? Can I leave it? Because I always do both, but it's always in the back of the mind, am I doing too much?
No, I mean, that's a great question. So unless the patient has isolated, elongated mitral valve leaflet that is coming in the way and causing MR, very likely these patients will end up having hypertrophied myopathy on top of having elongated mitral leaflet. So very likely you'll end up doing both, but I would carefully assess, and cardiac MRI is definitely a great tool for you to make the decision as to say, should I do a myectomy along with the repair of the mitral valve? So it's very, very unlikely that you could just see just isolated mitral valve elongation and then hence causing the LVOT obstruction. But very likely you'll end up doing both in most cases, but probably MRI will help you delineate which direction to take.
And often we see the young ladies coming with this hookup and they ask about getting pregnant. How do you advise them about getting pregnant, not getting? What are the cutoff values?
Well, great question. So I don't think there's a major contraindication unless their functional class is 3 or 4. Then you have to be cautious about, how you want to do it. But if they unfortunately get pregnant, we've had one case, we ended up doing a alcohol septal ablation in one of the patients who were extremely symptomatic, got into heart failure symptoms that did okay. But generally, if they're 3 and 4, definitely will say no, or obviously do the therapy and then recommend pregnancy. As you know, these are younger patients with hypertrophic cardiomyopathy. We can't prohibit them from becoming pregnant, but if we can treat them ahead of time, especially if you're following these patients, I think that would be ideal. Dr. Ahmad, do you have any insight into what you guys do?
I think I completely agree with you. I don't think there are any particular contraindications for patient subsets like this to go ahead with pregnancy. So we've had similar clinical situations where these types of inquiries and consultations have been made. But I cannot recall a situation where we've asked the lady in question to not proceed with pregnancy. I think the hemodynamics are quite favorable and can be managed quite effectively. But just to allude to the question which Dr. Gokhale asked about a patient with a gradients of 180 and hardly any symptoms, I would like to see the echo again myself and see whether we are actually the sample volume is capturing the mitral regurgitant jet as well, whether it's a true LVOT trace. Because if you capture the mitral regurgitation jet as well in the sample volume for the pulse Doppler, you're very likely to capture the mitral regurgitation jet. And what you have is a hybrid trace, and which can tremendously overestimate the gradients, or at least our estimate of what the gradients are. So I would have a relook at the image.
Very good point.
I had a patient for whom I did LV outflow tract relief plus mitral valve replacement. And after about 3 months, post-operatively, echoes were fine. She's doing very well. Came for 6-week follow-up. She's fine. But after 3 months, she developed a small VSD, and she came with failure. But of course, we could manage medically. But is there any way we can close percutaneously this sort of VSDs? Any experience?
I don't
No,
have any.
we don't have an experience.
Yeah,
No.
this happened after about 3 months. Must have probably infarcted, maybe a small
Possibly.
vessel or something. It's not, definitely not in the first 6 weeks. And managing it surgically is very difficult going back. But fortunately, she improved. I was literally praying.
One more point. These patients with HCM, their progresses because of the contribution to other risk factors also, for example, hypertension. So do we need to very aggressively treat, or our targets for treating hypertension should be lower? For example, we should lower them to 120 by 80. Is there any recommendation or any thoughts like that, Dr. Anandaram?
Yeah, it's interesting that the hypertrophic cardiomyopathy patients don't necessarily present with true heart failure as such. You know, some of those dilated cardiomyopathy who are hypertensive, they can easily go into pulmonary edema. Their pressures are really high and they have high pulmonary pressure. So they may not necessarily, a small percentage of these patients may end up having pulmonary hypertension as such from hypertrophic cardiomyopathy, unless they get into stiff ventricles issues and stiff atrial issues. So just lowering the blood, we don't have, first of all, we don't have clear data that we need to lower the target blood pressure systolic 110/60, may or may not really help in those patients. But if they're truly hypertensive, then I agree with you. I would treat hypertension, to the target levels as such, and make sure you reduce the risk factor there. But per se may not necessarily help. Dr. Ahmed, if you have any thoughts.
I agree, sir. I think there is a lot of data on patients who are genotype positive, but who are yet to express the phenotype. And I think there is a prevailing theory that additional stress in the form of, let's say, acquired systemic hypertension over lifetime can probably trigger the genetic cascade, sort of leading to the expression of the disease. We still have a few questions, but I'm afraid we're really we're really running short of time. And we've had a very interesting discussion on the very pertinent aspects of HCM, including this spectrum of heart failure and the phenotypic basis of heart failure and HCM. And we had another interesting talk regarding the key imaging principles in HCM. And CMR, as we know, is right at the forefront of imaging tools in HCM. So I would like to hand it back over to Dr. Bakir, please.
Thank you, Dr. Hisham. All of you agreed that the speakers have raised the bar of excellence. There's so much to learn from them, and really we feel inadequate. Like Dr. Gokhale said, that he's a surgeon who has to learn a lot more. We feel even as cardiologists, we have a lot more to learn and miles to go. I'd like to thank Dr. Hisham for moderating today's session. The speakers were outstanding. Dr. Anantram and Dr. Ashita, very well done. And you really left us awestruck with your wonderful presentations. I'd like to thank the panelists, Dr. Gokhale, Dr. Harikrishnan, and Dr. Dipali, for your thoughts and for your inputs and for taking the discussion along in our journey to excellence. I'd like to thank my colleagues once again, Karthik and Naga, for helping us put up this show. I think all of us have tried as far as possible to get the best speakers and best panelists so that we have the best discussion. Lastly, our attendees have come down by half because it's a Saturday evening. But for all of you who are still remaining on the show, thanks to all of you who have joined us in this journey to excellence. Thanks to Hallmark, Sheshadri and team for putting up the show together. Sheshadri will later give us a recording of today's proceedings so that it will be useful for those who couldn't attend and also useful for all of us to have a relook once again. Thanks to all of you, and join us again next week on an exciting session on dilated cardiomyopathy. Thank you and good night.
Thank you.
Thank you.
Thanks.
Good night.
Bye-bye.
Thanks. Good night.
Good night.